We're very happy to have Emily Oster with us to talk about schools. The way we will do questions, I just talked with this a couple of minutes ago with Emily. She's perfectly fine with that. We'll handle questions the way we did yesterday, so you can just unmute yourself and go ahead and ask Emily the question you'd like to ask her. So Emily, thanks again for being with us, and the floor is yours.
Great, thank you. So I'm going to share my screen, and we'll see if I have managed to learn to use Zoom over this many months. No, probably not. Here we go. All right, can you guys see that? All right, great.
Yes.
So, so thanks so much. Thanks so much for having me. So I'm going to talk a little bit today about the work that we've been doing on I've been doing on schools. Elhanan, let me just ask you, how do you want people to like raise their hands? What is our like system for how people indicate that they want to ask a question?
Anything that is convenient for you is fine, but I think that if you just want to focus on your presentation, maybe they can just go ahead and ask. But if you prefer a hand,
no, that's great.
Okay.
Yeah, just go ahead and ask. Perfect.
Yes, just go ahead and ask. Okay.
Great. All right. So what I want to do today is, so I've been working a ton on COVID and schools over the past, I guess now it's like 15 months or however long it's been. So I want to talk a little bit about sort of what the landscape was, the kind of data stuff we did, and then actually get into a couple of the sort of research products, because I think part of what has been different about this sort of this experience for me, this approach, is that we sort of started this. I started this whole enterprise very much in a kind of public policy, like let's try to affect what's happening on the ground space, and then it sort of morphed into, okay, now we're actually doing some sort of research pieces around it, but it's sort of it's kind of come in and out of that. So all right, so let's go. So sort of for those of you who are not kind of steeped in the COVID school world, to give you a sense of kind of what sort of has happened, and I know the U.S. context better than elsewhere, like some sense of elsewhere. So basically in March of 2020, basically almost all the schools in the US and Europe, and actually pretty much globally, sort of closed for in-person learning. There were some exceptions, Sweden being probably the most notable one that people talk about, but sort of largely everything kind of shut down. And I think that the reasons for that made a lot of sense at the time. So, you know, if COVID had been kind of like a flu, if it had been a sort of traditional flu, we know that that kids and schools are a huge source of flu spread, because kids are a very high risk flu group. And so in that scenario, if this had sort of been like an H1N1 kind of situation, school closures would have been a very important part of the mitigation. And so there was kind of a reason to close schools specifically. And then kind of as things moved through the late spring and summer of 2020, I think it became increasingly clear that in fact, this wasn't really like a flu, in the sense that partly in the sense that it was more serious for some people, but also in the sense that it did not disproportionately affect kids, that in fact, younger kids were among the least likely to be infected, and they didn't get very serious illness, and they in many cases seem to be less likely to spread than older people. So at that point, it became sort of, it seemed like we could open schools safely. So places in Europe and the UK sort of started to do some school reopening. The US did not open basically at all through June, but when we came to August and September, the sort of pace of reopening, the dynamics of reopening across the US have been really varied. So there were sort of some schools, particularly in states that were kind of aligned with our former president, that opened kind of very aggressively all at once in August, and then there are places that have stayed closed for the entire school year. And so sort of over the fall, there was kind of opening, not opening, and then there was more of a push for opening in the kind of winter spring period. So there's, and actually this, so let me start with this, and I'll go back to the learning stuff. So this is a kind of way to visualize. It's not my graph, so I wouldn't have done it quite like this, but this is sort of a way to visualize kind of how things have looked. So the bottom of this graph kind of down here, this is November, and up here is June. And so you can sort of see kind of in November, and this is probably roughly where much of the fall was. It's about 36% of the US sort of enrollment was kind of had access at least to full in-person schooling. About 45% had access to some kind of hybrid situation where they could be in school some number of days a week or some number of hours a day, but not full in person. And about 19% of the sort of enrollment weighted kids had fully remote schooling. And that kind of grew over the December period as we got we had a sort of winter surge here. But then there's a pretty marked change in January, where we see more of a transition sort of away from virtual into either hybrid or full in person. By the end of the year, the sort of share of kids who had access to only virtual learning was fairly small, very small. It's a lot of California. So California is kind of has been sort of the most resistant to reopening. So that's kind of the broad landscape over the last year here. These sort of lack of school openings have had fairly significant consequences. So one way to see this is to look just at the spring. So just to sort of like ask when we shut schools in March of 2020, what happened to learning? And so actually it's sort of interestingly been proved to be somewhat difficult to figure out exactly what's gone on with learning, because in the US we have these like standard tests that are given every year. So that's our sort of standard way of tracking is with something like the NAEP tests. But they basically didn't do any of those this year because nobody was at school. So we actually are missing those pieces. But there are other proxies, other ways to try to get at that. And one is this particular math program called ZERN, which is something that's used by at least a reasonable share of school districts in the US. And you can track very finely how kids are doing because it's intended to be sort of done every day. And so there's a thing called a badge that you earn when you kind of get to the next level in this program. And so what you see, and this is the spring of 2020, what you see is kind of when schools closed in March, there's a large drop off in the badges. You can sort of think of this as like amount of learning. So sort of in aggregate, there's something like a 30-40% drop in the kind of amount that kids are accomplishing. But that drop is hugely larger in low and middle income school districts or schools relative to higher income schools. So this.
Sorry, this is 2020.
Yeah.
Sorry, this is 2020.
This is 2020.
Okay, so until March there was essentially nothing. That's standard. Yeah. Okay.
Yeah. So then when we sort of go to the fall, I think there was a lot of discussion about sort of when we arrived at the fall of 2020 into the sort of new school year, like maybe remote learning was going to be amazing and like, we were going to do a great job. That does not seem to have proven to be true. I think that the learning losses are probably smaller in magnitude than maybe suggested by this picture, but we are seeing some pretty significant evidence of sort of losses in math achievement, losses in reading achievement. We're also seeing just a lot of fewer kids in school. So actually there's a huge enrollment drop, and it's not totally clear how much of that will be kind of eventually made up. So some of it is people not sending their kids to kindergarten. Some of it is kids dropping out of high school. So we're sort of like grappling with that. And on top of that, there's a fair amount of mental health stuff. Yeah.
Sorry, I had a quick question.
Yeah.
I was wondering how large this data set that they're getting this graph from is, particularly because you see after the large drop a sort of uptrend for some time. And I was wondering if we would be able to catch any significance out of that, or if it was just kind of a random, like, okay, went up a little bit, went down.
This is a pretty big data set. ZERN has pretty good coverage. So I think that recovery is real, and that recovery is reflecting some of what we're seeing later in the fall, which is like when you wake up one morning and tell people, okay, teach people in their bedrooms, like they're not going to be great at that tomorrow. 2 weeks later, there's like a little bit more adaptation. At the end of by the end of the summer, there's like more adaptation. So things were easier. The sort of remote learning was better in the fall. But so I think that's a real thing. It's a big deal.
But did they have a recovery and then they drop again? Is there like that seems
this
like
is the end of school. So that's basically schools basically just like a lot of schools just ended in May. And then that's like, particularly last year, it was just sort of like, forget it. We're just like, let's get a do over later. Okay, so what I'm going to talk about today. So I sort of, that's like a little bit of backdrop. What I want to talk about today is basically the sort of process of trying to create some data, generate some data about COVID and schools in the US. And then a couple of things on sort of research that has kind of come out, findings that have come out of about school reopenings and what's safe and what's not safe, and sort of equity that it's come out of that data. Okay. So in August in the US, I mentioned we sort of started to see some schools open. And just to give you a sense of the dynamics of this, basically what happened is at some point in July, President Trump, former President Trump, thank goodness, said that schools should open. So he sort of made a pronouncement like we should just open schools. Everybody should open their schools. And an unfortunate consequence of that was that sort of the decision to open schools then bifurcated very much on the like, are you with him, are you against him lines. And so a bunch of schools in places that were very aligned with Trump just kind of opened, and they sort of like opened pretty regular, largely without masks, without a lot of precautions, pretty full density kind of opening. So Florida, this is sort of somewhat missed, but Florida basically opened all of their schools in like August and stayed open more or less fully in person for everybody for the entire school year. So that was like kind of one approach. And then there were a set of blue states, which kind of like sort of blue school districts, more democratic, that kind of then just went in the other direction. That was like, hey, we're not going to open, or we're going to be open differently, and they ended up largely not opening. So when this happened in August, we then sort of started to see, okay, these schools are open, and we started getting kind of pictures out of some of these schools, particularly out of some, there's like a set of New York Times articles about like schools in Georgia, where they had like pictures of these crowded hallways and none of the kids wearing masks in these high schools. And I think it generated a tremendous amount of anxiety and fear around people that, okay, this is going to be like a super spreader. These are going to be kind of like super spreader events. There was actually already at that point some fairly encouraging data from Europe about sort of the possibility of opening safely. There was some less encouraging data from Israel, where there were a couple of more significant outbreak events, particularly in older kids. But also at that point, the U.S. COVID rates in a lot of these places were very high. So, we're kind of opening schools in Georgia, but the COVID rates are, 100 and 100,000 daily case rate or something. So like, way outside of what had happened in Europe. So I think it was just hard to know how to take that. So at that point, there were I think there were sort of three big questions that people had. So one was, are these schools, sort of I phrase as, are schools super spreader? So are we going to see like big spread events associated with them? The second is, to the extent that there are some of those, what are the mitigation factors that matter? So Europe and Israel took actually fairly different approaches to this. Some places in the US had masking, some didn't. They had distancing at different rates. There was sort of a bunch of mitigation things going on. The question was, which of those things are important? And the third was just, if there is spread in schools, like what is it between who is that spread? And those felt, I am a person who likes, like many of us, like I like data. I think that we can learn a lot from data. I think that it is something that can inform our decision making. And it seemed like these questions were answerable. And whether or not you thought it was a good idea to open schools in Georgia, you certainly should think that it was a good idea to learn from that school opening. You should think it's a good idea to basically say, okay, like you did this thing, which a lot of people think is really dumb, but like, let's not lose that opportunity to learn about learn about it. But there was actually no sort of centralized data collection at the federal or in most states. Kind of no efforts to kind of collect any information on how much COVID there was in schools, how many people there were in schools, whatever. And the reason for that is a combination of a sort of total failure of leadership at the Department of Education and the Center for Disease Control in the US on these topics, and the fact that the US has a very decentralized educational system, which makes it very difficult to collect these kind of data. So there's 13,000 school districts in the US, and they are largely autonomous. And so it is in many states, there is simply no way for the state to know how many children are enrolled at the school district. Like, they just don't know that. And there's no way really for them to compel the district to report that to them. And similarly, the federal government has no way to compel the states to collect these kind of data and to report them out to them. They can incentivize them. They can say, we'll pay you for this, but of course that takes money. And there's kind of just no, they just can't make them do that. So they weren't doing that. So we decided to try to do it ourselves. We decided to try to do it ourselves. So I got together with a bunch of sort of education policy people and some data people. And our goal was really very simple. It was basically to try to figure out, okay, which are schools open, which schools are open, how many people are at the school, how many staff is at the school, how many kids, how many teachers and other staff, what kind of mitigation are they taking and are they undertaking, and then just follow them over time and see how much COVID they had. That was like the super simplest thing you could imagine. You'd imagine doing. We took a sort of kind of two-pronged approach. So initially, we actually just asked schools and school districts to participate, which leads to what you might imagine as a somewhat biased sample, but it was an easy sample. And then over time, a number of states actually started providing fairly consistent data, and so we sort of scraped that down and we put it in our data thing. This was not initially intended as a research project. So I'll show you some of the research that has come out of it, but the initial idea was to actually provide this information as quickly as possible to people trying to make decisions. And so we got this data in, we got in the data that was reported by the schools or the data reported by the states. We put it on a dashboard. We just put it up on a public dashboard every other week for the entire school year. We started in the beginning of September, and sort of by the time we ended, we had about sort of a pretty consistent sample of about 12 million enrolled students, about half of whom were in person. So on the one hand, as a research product, this is kind of weird because, it's some of it is opt-in, some of it is sort of these whole states, but it's only the states that report it. On the other hand, I think, it would sort of came in at a time in which there wasn't much else around. So what do we see? This is kind of the basic picture of what happens in the dashboard. So we calculated case rates. So this is case rates in two groups. This is basically converted to daily case rates per 100,000 people. So it's the standard way that we're quoting in here, probably you guys too. So the bottom starts the first 2 weeks of September, going to the last 2 weeks of May. The red line is the staff. The gray line is community case rates and sort of matched communities. And the blue line is students. These, I just want to be clear, the sort of community case rate and the school case rates are not kind of directly comparable. Because we don't know, there's differences in testing frequency and all this other kind of stuff, but it's kind of one benchmark. And I think the other thing that we want to be very
what is community? Sorry, can you say again, what is the community case?
It's the zip code that the school is in. So it's whatever is the case rate in the zip code that school is in.
But it's still only kids in school. You are not talking about the general population.
No, it's the general population.
Oh, it's a general population in not in school. You mean everybody from age 0 to age 100?
Yes.
Okay. Thanks.
Yeah. So basically, I mean, I think, from our standpoint, and to take a step back, the sort of first thing we wanted to do was just collect this student, like the case rates among people in school. So this is like the school tells us, or they tell the state, like, this is how many students we had here, this is how many teachers, and this is the number of COVID cases we have. And that lets us calculate basically a case rate among those people in the school community. Now, that is, just to be clear, that is not cases spread in school. That is cases in people who are affiliated with the school. So they may well, in fact, we know from sort of other information, almost all of those cases are acquired outside of school. So even if there was no spread in school, we would expect there to be cases in people who are in school because they got them elsewhere. So at some point early on in this project, we realized we needed a way to kind of talk about, okay, what would you expect? Like, what are the case rates you would kind of expect, or what do we think is happening in the community? And so to do that, we pulled in this sort of overall community case rate. It's not an apples to apples comparison because it's not a demographically matched population, and because we don't know about the intensity of testing. So it's a sort of it is probably the best comparison we can get, but it's not perfect.
Can I ask about
Yeah.
that? You were saying at the outset that it was believed that school children had lower case rates than the rest of the population, but from this graph, it looks as though it's about the same. Can you comment on that?
Yeah, so that is what comes out here. In general, kids do, if we sort of looked overall across kind of like age groups in the US, you definitely see lower rates in kids than among the sort of older, the older population. Although actually, case rates this is like includes high school kids. It's actually case rates in high school kids are reasonably high. That's actually not a super highly protected group. The group with the very low case rates are sort of very little kids. The kind of seriousness scales with age also. So, I think this is not exactly aligned with what we see in the with what we would see in the kind of overall age grouping stuff. But I think part of it is about testing. So the sort of in-school populations are tested at higher rates, and so that's actually particularly true in the staff. So like a lot of this staff numbers are driven by New York. So in New York, where we have very comprehensive data, the staff case rate is much higher than the community case rate. But actually, we also know from elsewhere that the staff are being tested about 10 times the rate of the general population. And so there's a sort of like kind of, because our testing situation is not that great here, like there's a kind of weird mismatch there. But yeah, that's what this data.
Have people tried to correct for the differences in testing rates?
Not really. No. You could do that. And I think people, I think part of it is that like in some ways, the most convincing thing that came out of this sort of initial kind of pull on the data is the idea that just there's not a lot of super spreading. Like we're seeing individual cases, we're seeing isolated cases. I might have a picture of like sort of distribution, but like we're not seeing huge outbreaks at school. It's not that they're never, but like we're not seeing a lot of them. This kind of data is very good for that, because even with a relatively small amount of data, if you're seeing big super spreader events, you can kind of see them, even if your data is pretty limited. When people then wanted to move into like exactly how risky is this, there was, I think, much more interest in focusing on are we seeing spread in school? And there was sort of like taking advantage of a smaller number of places with really good contact tracing data. That was kind of the direction people pushed, rather than trying to like do something with sort of this kind of data in a more adjusting way. Michael?
Yeah, sorry. Is that average daily case rate? Is that per 100,000?
Yep.
Okay, making sure.
Yep. I guess one
Question?
thing that's also probably worth saying when you just sort of think about the kind of whole landscape of this is that the places that opened schools or kept schools open in the US are by and large the places with the highest case rates. So the sort of correlation, sometimes people will say, well, you know, the like places that have their schools open are the places with low case rates. It's actually the opposite of sort of what happened. So places like North Dakota, which for a while had case rates, you know, like 450 per 100,000 or something, and they actually had their schools open at case rates like that. Whereas a lot of places where they were closed. Now, that was perhaps not a good idea. It's hard to say. But the sort of correlate, like it's not right to read the scenario in the US as places opened when it was safe. In fact, a better way to organize it would be to say that places opened when we wouldn't have thought it was safe, and were closed at times when people more thought things were safe.
Question?
Yeah.
Do you have a sense how many of what you call staff were associated, were going to just one school versus those that were going to multiple schools? Because kids only go to one school. So if that school is infected, they may get infected. If not, they're safe. But some of the staff, I imagine there are teachers that only go to one school, but there may be other teachers that go, you know, during the week. They have a few days at one school, a few days at another school, which means that they may be susceptible to many more places of infection than just one place.
Yeah. So we don't have a sense of that in these data. You know, what I can tell you from sort of other data that we have on school stuff in the US is that that to the extent that there are staff who are, to the extent that we see in school infections, which is fairly limited, actually, most people who get COVID who are teachers or other school staff are get COVID somewhere else, not getting it at school. But to the extent people do get it at school, it's almost entirely from interactions with other staff members. Now that does not answer your question, because that they could be exposed to more staff at different at different places. But I think a lot of it is kind of like staff interactions in the lunchroom. Basically, people like take their masks off and they eat together, and then that's when you get them. That's when you get the COVID.
Yeah, but still, the fact that much of the period was double the rate, I mean that needs some explanation. Yes. Somehow.
I mean, I think it's like I think that this is definitely like, I think what you see here is like, this looks like a higher risk group. For sure, the staff is a higher risk group.
Most of the time it's double, not just higher, it's quite significantly higher. Double the rate, yes. If you look at the absolute number, sometimes even more than twice. But most, you know, until everything starts going down, which I guess it's February.
So basically, this is when the vaccines hit. Now, one thing, I mean, I think the other thing that like is just sort of a little like this point, this dot here, this is the first week after our holidays. And so at this point, almost no one has been in school. So like basically these infections are like almost could not have been spread in school because they are the kind of post-holiday infections.
I see, but it's a lot of testing that was done immediately after the holidays when they came back.
So New York tested about the teachers at 10 times the rate of the general population over this period. So I mean, again, it's like, you know, it's a sort of part of what's frustrating about these data is that there are pieces of them that are just very hard to interpret because they are not the data that you would most want to kind of track how much transmission is there in schools.
Yeah. So it would be interesting to see just infection rate relative to testing. I mean, how many positive tests there were to get a sense of a baseline.
Yeah, so I mean the positivity rates are obviously way lower than the overall positivity.
Yeah, I know, but to compare between the students and the staff in terms of positive testing.
Yeah, and the best data on that also comes out of New York City, where they'll sort of report out basically when they do asymptomatic surveillance testing. They're sort of consistently finding rates that are way lower than what they're seeing in the community. Again, it's not like a perfect comparison. But New York did a fair amount of that kind of sort of surveillance testing of the students and the staff. Okay. So this is just another way to sort of think about the super spreader question, I guess, is that this is the kind of density counts of cases in the sort of first, this is sort of the first half of the year in New York, where we have much more detailed data on this. So you see, most schools in a given biweekly period have no cases, but among those that have them, it tends to be a relatively small number, sort of one or two. It's not that there's no episodes of spreads. There's, for example, like one Catholic high school in New York, not in the city, but in the suburbs, that had like 60 cases. That sort of obviously suggests that there's something going on there. But it is not. But mostly these are kind of fairly isolated incidents.
So just understand, those are the number of cases in a period of 2 weeks in one school, right? That's
Yep.
what you.
Exactly.
Okay. Let's say one, it means that's so 10% of the schools, and during a period of 2 weeks, just one case.
Yes,
looking
exactly.
That's
Yep.
how I read it. Okay.
That's how you read it. Okay. So there are a bunch of limitations of these data, like sort of, I think many of which have been sourced here and certainly have been raised elsewhere. So some of the data is kind of what we'd say is like an opt-in, although I think I think the truth is sort of as we get later towards the end of this period, that's kind of much less true. I think the biggest limitation of these data is that there isn't any contact tracing. So what we see is like how many teachers are associated with associated with school have COVID, but we don't know, where they got it. And there's a sort of like interpreting that kind of staff rates are higher than the general population has a bunch of different interpretations. So one is like that's a kind of a general population rate. It's not a demographically matched rate. Another possibility is, well, it's not that another possibility is they're getting it at school. For that, we need better contact tracing. Another possibility is, they're not getting it at school, but they're getting it on the way to school. So it's something associated with the sort of being a person who works at a school is giving you COVID. For all of those things, we would sort of need better contact tracing data, and that's not in these. That's not in these data. There's other people that have sort of followed up in more detailed ways on smaller populations that have gotten to kind of the same. That have gotten to do that, but that's not something we see here. I think a related point is that you sort of ideally like a better kind of comparison rate. And the data lacks a fair amount of geographic diversity. It's sort of concentrated in the states with good reporting. So there's sort of comprehensive data here from New York, Massachusetts, Texas, Florida, and West Virginia, but not elsewhere. And I guess the last thing that's sort of worth saying here is like you can really see vaccines. So you can see particularly the U.S. really prioritize teachers for vaccination. And you're seeing, this is sort of when that's going to start hitting. And then it's just been, rates have been really, have been really low following that, which is good. Okay, so given these limitations, you might think like, well, is there anything one can do with this? And I'm actually going to talk about sort of 3 projects that have come out of versions of this data. So the first is the question about 3 versus 6 feet of distance. Okay, so what does this mean? So we've all sort of heard versions of the kind of there should be 6 feet of distance of people between people. The CDC, as part of their kind of package of mitigation strategies at various times over the year, recommended 6 feet of distance between kids. Now, what does that actually mean? For those of you who have children, you will understand it's difficult to encourage your children to distance themselves at 6 feet. So really what the CDC kind of meant here was enough like physical space to be able to distance the kids at this distance. So to be able to sort of put this amount of distance between the kids. The WHO went with like a 3 feet distance rule. And US schools, the sort of CDC doesn't tell you what to do, they just make guidance. So the CDC US kind of opened in different modes. So some schools open at 6 feet, some schools open at 3 feet, some schools actually didn't adopt any distancing at all. They just kind of opened in a normal way. This turns out to be a very, very important issue in the US in terms of schooling, because there are many districts that basically could not open sort of like regular full-time learning with a 6-foot requirement. There's actually some that can't do it with a 3-foot requirement either. But the 6 feet was like particularly constraining because you just like literally don't have enough space to fit all the kids in if they have to be 6 feet, if you have to be able to have them 6 feet apart. And so this was a thing that got in the way of opening for a lot of places. So there was a lot of interest in understanding, okay, well, is this distancing like associated with lower case rates, or are we just like kind of constraining ourselves for no reason? This is a difficult empirical problem for all the kind of standard causality issues. The choice of distancing is driven largely by the states, sometimes by the districts. It's like pretty endogenous to other things about how you're doing other things you're doing. And also to some extent to case rates in kind of both directions. So sort of a very difficult thing to do, and comparing across states is really challenging in this environment because so much of the sort of overall COVID policy was set at the state level. So there were huge variations there. But what we did, and this is a paper that sort of our dashboard team wrote together with some researchers at Harvard, sort of like some medical people. So what we did was we basically used one of the few states where this was a explicit choice. So Massachusetts told their school districts at the beginning of the year, you can choose 3 versus 6 feet. So there were some things they told them they had to do. They told them that they had to have everybody mask all the time. They told them that they had to improve their ventilation in some way. So typically that meant like putting in HEPA filters. They got everybody HEPA filter. And for all the classrooms. So there was sort of those things. But then for the distancing, they told them you can pick. Now, of course, like this choice is not random. You know, districts made it in some way, but in practice, there seems to be quite a lot of noise in how they chose it. It's just sort of like it's not really obvious when you push into it, like why some place chose. And when you look at the list of places, they're kind of like pretty similar. You know, they're like, there's like places that are next to each other that chose these sort of different things. So we did basically a very simple analysis. So on the dashboard side, we had data from the school districts on the enrollments, the in-person counts, and the number of COVID cases. So that's sort of like provided by the state, which we had used in the dashboard. We had for each school district over time, effectively these COVID case rates. And then we combine that with these mitigation data with whether the school district chose 3 versus 6 feet. And, you know, just to be clear, this is coded up from their district plans. So someone had to go through, you know, there's like, I don't know, hundreds of districts in Massachusetts. You have to go through every one to read in their reopening plan, like, what did you choose to do for the distancing? Okay. And this is what they say. Now, whether they actually restrict the kids to be distant from each other, like that, I'm sure that they can't do that because nobody can keep kids apart from each other, but their goal was to keep them apart. And then we did this like very simple.
Sorry. Question: yeah. The phrasing of the instructions to the schools was neutral in the sense it didn't say like if you can 6 feet, do it. If not, 3 feet is also okay, or something in that manner.
What did so the phrasing by the state to the districts? Yeah, it has a little bit of that. It does have a little bit of that flavor. I think that it was sort of like 6 feet is the best, but 3 feet is okay. And you can open at 3 feet. You know, that shouldn't get in the way of your opening, something like that. Then we just graph the rates for these two groups over time. So that's like this whole project. This is it. This is just a picture. And so what you can see here is the case rate per 100,000. The top two lines, the gray and the blue lines, are the staff rate in the 3 and 6 feet. The blue is the 3 feet distancing places. The gray is the 6 feet. You know, there's obviously some noise in these data. Samples are not enormous, but you know. And then the bottom is the student case rate. And when you kind of like dig into the into the data pieces, into the sort of regression versions of this, where you aggregate everything together, you certainly cannot statistically distinguish these two groups. They don't look like they're very. They don't look very different. It does not look like the sort of 6 feet of distancing is particularly any better than 3 feet of distancing in terms of reducing spread. Now, one of the things people say, well, maybe 6 feet's not enough. And I think that's like kind of not, that's kind of a totally reasonable statement. You could similarly say, well, maybe 3 feet is too much. Like maybe it doesn't matter if you distance at all. What we can do here is we can say, your policy was, there's this policy, it's 6 feet. There's this other policy that's 3 feet that would allow more schools to open more in person. It certainly doesn't look from these data like 3 feet was buying you a lot, 6 feet was buying you a lot relative to 3 feet in terms of reducing case rates. So that is like that full paper, as I learned as an economist.
I may ask. If this was just a declaration essentially of intent, that's what you intend to do, or does this have practical implications, like a school with they decide on 6 feet, halved, say, the number of people in class, whereas a school that decided on 3 did not, say, because they could fit enough people, but once they decided on a school that decided on 6 couldn't fit everybody in class, so they split the class into 2. Now that's a real factor. Versus just saying to kids, okay, keep 3 feet or keep 6 feet, which is very hard to implement, of course. And if most of it was something like this, then I would not expect a big difference. But if the question is how many schools there were actual real consequences to that decision, that's what I'm asking.
Many. So many schools, and in fact, when schools implemented this policy, it was not just to say, try to stay 6 feet apart. They needed to show that they could have a certain that they had enough space in the classroom for the students to sit 6 feet apart. So for many schools, the restriction to 6 feet meant that they could have the kids only there half the time. So sort of like they had to have 2 cohorts and they would split the class in half. So you basically couldn't offer full-time in-person learning. And in fact, when the CDC early in the spring, the CDC reiterated their view that 6 feet was necessary. There had been some schools that had been planning to open more fully who had to pull back who said basically, okay, well, since we can't move to 3 feet, we have to pull back to 6 feet. So we're not going to be able to have students back in the classroom. So this was not just like, hey, try to stay further apart. This had like very real consequences, but it required them to be able to have the kids that far apart in the classroom.
So follow up on that would be interesting, rather than seeing 3 feet versus 6 feet kind of graphs, seeing schools where the number of kids in class stays the same versus schools where the number of kids in class was halved because of different days.
I'm going to show you that in the next paper.
Oh, okay.
One of the best things about science papers is you can just write the same paper like 50 times. And then you just have like a lot of different publications. So this is a whole paper, just one graph. I'll show you the next graph is another project. But yeah, I totally agree. All right, so from this, we basically argue that these sort of rates were not different in these two groups of schools. And that, particularly in this setting, like in Massachusetts, where we had better ventilation, we had this masking, that it was possible to operate with this sort of less distancing. And actually, we came out with this, and then about a week later, the CDC changed the guidance to 3 feet. So I think there were a few things that came out around the same time, but I think this kind of mattered. This mattered for their decision because we were in such a information dearth that even this graph with 4 lines on it was more information than we had before. And I think this is part of what Massachusetts basically. Like the CDC changed their guidance and told everybody you got to go to 3 feet and you got to have everybody back in the classroom in the spring. And I think we saw more reopening, at least in part due to that. It's good. All right, so now we're going to talk about other mitigation, and we're going to get into this question about density. So that the sort of 3 versus 6 feet is one mitigation, but there's a lot of different mitigation things that are enacted in schools. And there's a question of whether they make whether they made a difference. And sort of this is in some ways a sort of like look back academic question. I think it's not totally a look back academic question because in practice, we're going to be having some of these same debates in the fall, I think, or at least there's a reasonable chance that we'll be thinking through some of these same prevention questions in the fall. So to do this, to sort of try to think about this, we took data from kind of 3 of the states where we have the most comprehensive and detailed data. So that's New York, Massachusetts, and Florida. And we're actually going to look at sort of 3 different things. So the first is density. And this is basically this is how many kids are in the classroom. So this is like what share of your enrollment do you have in person at a given time? It's going to capture like distancing, opening mode, it captures sort of a bunch of things. But you want to think about like there are places where the sort of density in the classroom is 50%. There are places where 30%, places where it's 90%. And that sort of goes beyond like some stated policy. It's not the same as saying how close are people because you know how big the place is. But it does capture some of these things sort of in this space of just like what would happen if we actually brought everybody back, if we had sort of a full density like regular school, whatever that means. The second thing is ventilation. Are there improvements in ventilation? The question is literally, did you improve your ventilation? So could mean almost anything. And then the third question is masking. So a lot of places in the U.S. did required masking for everybody all the time. But Florida had a choice. So similar to the sort of 3 feet to 6 feet in Massachusetts, Florida gave districts a choice about whether they required students and staff to wear masks. That's different than saying that they did or did not wear masks, but they asked if they were. The question is, are you mandated? Are you required to have everybody mask all the time? And just to be clear, in the U.S., in a lot of places, the masking requirements go down to very small kids. So at my kids' school, everybody down to the 3-year-olds was masked all the time, all year, for like including outside. So we have like a pretty aggressive child masking culture that we're engaging in over here. All right, so we're going to do again a sort of super simple analysis. We're going to like basically regress COVID rates on these mitigation things, controlling for community rates. Obviously, this is a difficult causal problem, which we will not make an enormous amount of progress on. A lot of these things move together. So, you sort of think about these as correlations, and we try to see what we can glean out of them. All right, so here are the density results. So I'm sorry that these graphs maybe could have been improved. So the omitted categories, these are regression coefficients over time. The omitted category here is the lowest density. So these 2 lines are sort of, the blue line is kind of intermediate density, and the red line is the highest density. So you sort of think about like places that are in person but are less than 50% is the omitted category. The less than 50% of the kids are kind of in person, then 50 to 80% is the blue line, and greater than 80% is the red line. So fairly consistently across this data, we are seeing for students that higher in-person density is associated with lower case rates. So the places where the schools or districts where the density is higher are seeing lower case rates than the places where the density is lower. So that's sort of the opposite of what you'd expect.
So is there, do you believe the way to explain that is to say, well, these kids that would be going to school 50% of the time and maybe they go to the mall or they go here, if they're not in school half the time, they're actually more safe now because they're in a safer environment a larger amount of the time?
That is the argument that we suggest is a possible explanation. And I think that is the most coherent argument. I don't think it's like I don't love it as an argument because I would love to understand, do you know what I mean? Like, I don't have any reason other than just intuition to think that is the most plausible explanation. But yes, that's something like basically if you're at school 50% of the time, you're doing something else 50% of the time. We kind of haven't, we sort of imagine that people are just like hunkered down in their homes, but they're not, they're doing something else, or they're at the Boys and Girls, like they're sort of being cared for in some other care environment. They're at the mall, they're, hanging out with their friends, whatever it is. And that those are less safe. Those are less safe environments. For the staff, the density is pretty much a wash. There's a sort of brief period in New York where the higher density places are kind of slightly higher case rates. Overall, it's mostly zero. It's mostly zero in all of these three places. So it certainly looks like the density for students is if anything sort of going the other direction. I think in some ways the student piece of this is the most important for the sort of going forward into the fall, because at this point the staff vaccination rates are really high, and so we're really going to be sort of in the fall thinking about how are we protecting the kids how are we thinking about the kids under 12 who cannot yet be vaccinated. So here's the ventilation data, the ventilation results. And I think, to be, this is like coefficients over time for places with ventilation improvements versus not. I think a pretty unfortunate aspect of how we ask this question is just that we don't know what it means. And so, like maybe there's kind of nothing here, but I think a very legitimate question, which we just don't have a great answer to, is like, well, maybe there are some kinds of ventilation improvements that matters a lot, which I'm sure is true, given what we know about the aerosolized nature of the virus. I think we and no one else was sort of quite focused enough on the ventilation piece of this in the fall. And so one of the aspects of that, one thing that meant is that places didn't sort of spend a lot of time saying what they did to improve their ventilation. So anyway, but we're not seeing much there. And then we turn to masking. So these are again sort of coefficients over time. The omitted category here is places where there are masks required for everybody all the time. The red line is no masks, and the blue line is staff masking only. So there are districts where they said the staff needs to wear a mask all the time, but the students do not. And then there are districts where everyone wore a mask all the time. That's the omitted group. And then there's places where nobody was required to wear a mask. Of course, they could have worn a mask, and probably many people did, but they were not required to do so. And we're not seeing we're really not seeing much. There's kind of no significant difference between these groups in terms of their case. There's no difference in the case rates here, which is frankly I think is surprising, and I'm not quite sure how to interpret it. The only sort of like we see a little bit of a kind of hint that in places at the red line where even the staff were not required to wear masks, that maybe we're seeing sort of slightly higher case rates in those staff in those places, although those are also places with reasonably high community rates, so it's a little hard to separate those things out. So I think that so this is something we're trying to follow up on, but I think the a little different than what we might have expected. Also, it's only, I should be clear, this is only data from Florida, and so some people have pointed out that they think that the Florida data is not the best, and it seems possible. Okay, so I think the final thing to sort of say about that, and then I'm going to talk about this last piece of evidence on equity, is that kind of the overall picture from these three states, and actually from sort of everything in the dashboard, is that after vaccinations were widespread in the spring, there's just much lower rates kind of across the board in everybody. So if we sort of think about kind of planning for the fall, talking about the fall, almost none of these things matter in the spring, because case rates are just really low after vaccines are widespread, because a lot of the cases that we're seeing, to the extent we're seeing cases, they're largely in staff. Okay. Finally, I want to talk about sort of equity. So question here was just, how does school reopening affect students across racial groups? So what we do here is we merge basically district level reopening data from across the US with some demographic information on districts. It's like a very simple analysis. And we're going to ask sort of two questions. So what do the differences in access look like in the fall? And how does the spring sort of reopening period, how does that affect these groups differently? Okay, so I should just be clear. We wrote this paper for the CDC MMWR, and they have a lot of really crazy requirements. So the graphs looked so nice at the beginning, and then they sort of like deteriorated into this like disaster. But anyway, I'll try to walk us through them. So so over here, this sort of box A here, it shows the share of kids who have access to a full-time in-person learning environment. So that's kids who, if they wanted, could come to school 5 days a week for the whole day, every day at school. And so that number is sort of lowest in kind of January. It's sort of like a little higher here, it kind of declines, and then it goes up. And the average number here is about 40%. It goes up to, maybe on average, like kind of 60% by April. It is always, and this is kind of the big point in some sense of the paper, it is always higher among white students than students of color, of any students of other races or ethnicities. But actually, the sort of relative increase, the sort of increase in this access to full-time in-person schooling among white students is larger in the spring than the increases for these other groups. So the gap here is much smaller than the gap up here. If we look at the other, so then there's these sort of other two things. There's the hybrid and there's the virtual. Obviously, they all add up together. So I just want to talk about the sort of two extremes. So if we look at the access to virtual only learning, that's declined over time, quite a lot over the course of the year. But it is always lower among white students, and the gap there sort of falls over the sort of between white students and others, kind of falls in the spring. So sort of putting these pieces together, we're seeing sort of both kind of initial pretty significant inequities in the fall between in-person sort of access to any in-person learning. So in this kind of period in early November, something like only 30% of white students have only access to virtual schooling, whereas that's like 45% or something of students of color. So we're seeing this sort of initial kind of white students have better access. In the spring, in a good sense, access improves for everybody. So students of color are more likely to start getting access to hybrid forms of school and to some extent to sort of full in-person learning. But actually, there's a sense in which some of the inequities increase because we're seeing an increase in the sort of size of the gap between white students and others in the access to sort of what we would think of as the gold standard, like kind of full in-person learning. Yes, Sergio?
I apparently I'm not aware of the degree of segregation in the US, but you classify the school as white or black or Hispanic, right? It says schools. It's percentage of schools. It's not students. So you can each school decide what is to what ethnicity the school belongs. Now,
no, so I should have said that. So we basically weight the district based on their, so like if we sort of take the demographics of the district, and if the district is open sort of full in person, then we classify the Black students in that district as having access to full in person, the white students having access to full in person, the Hispanic students having access to full in person. So there is a lot of segregation, but we're not classifying schools as Black or white. This is a sort of like student
percent. Oh, sorry. Okay, sorry. It's font is too small. Okay, it's percentage.
Sorry.
No, I misread it. For some reason, I read it as percentage of schools, and that's why.
Of students.
Okay, sorry. It says students. Okay. Now I need better glasses. Sorry.
So yes, it's percent of students. I think it's also worth sort of saying here that that if anything, this probably understates the degree of inequity in in actually having these kinds of learning experiences. So this is really accesses, like, could you go? But in practice, we know that the opt-in rates also differ quite a bit across racial groups. So even when given access to full in-person schooling, Black families are less likely to opt their kids in. We're less likely to sort of switch to opting in the spring. So if you sort of measured this as the share of kids who are actually in school, you would have these inequities sort of look even larger. And so sort of what we took away from this is there was a fair amount of kind of like, I don't know, like self-congratulatory back patting in the US around, okay, well, we reopened a lot of schools in the spring, like toodaloots, we did such a great job of that. And in some sense, yeah, like that was good. A lot of schools reopened that weren't open before. And that did, result in better access to learning for a lot of students who had been given only virtual access for a long time. But the kind of way that this happened didn't really fully achieve didn't fully achieve a return to kind of equity, and actually generated its own sort of additional kinds of inequity over this period. And I think what we sort of say in the second bullet here, like all the groups have less virtual learning. That's great, but like the reduction was biggest for white students, even though they started at the lowest level, right? So it's like they're doing better, even though they were already doing better. Now they're even doing more better than they were before. And so we sort of look to the fall on this, figuring out a way to open in-person learning to all kids in an equitable way is going to be like really important. And I think it overlaps with some concerns about inequity in vaccine access. So if we think like the key to opening schools safely is to have very high vaccination rates, we're also seeing differences across communities in vaccination rates, which is something to like be aware of when we're doing that. In practice, the biggest vaccine inequities are across political lines and not across racial lines, I think, at this point. So that may be less important, but still something to sort of that we should be thinking about pretty carefully for policy.
Emily, can I ask a quick question?
Yes.
On that last point, if you looked at the opening, if you sort of made the benchmark not equity but fulfilling household preferences, and so suppose if there were inequities in health status, like likelihood of having severe COVID or not being able to get good hospital treatment for COVID, is it obvious? I mean, the narrative that you hear a lot is that the poorer minority communities aren't eager to take it up, and so at some level it could just be efficient provision at the local level of this public good. I mean, it's related to this issue of public goods being so localized in the United States to begin with, but how do you reconcile this kind of equity benchmark you have isn't in some sense the usual public finance one we have in the US?
Yeah. So I mean, I think I have a sort of, and so I should just say I'm actually done, so I'm happy to just take like a lot of questions. And I'm gonna stop my sharing so that I can see more of you. So I think that conversation feels very complicated to me because we have seen very big differences in opting in across the sort of different racial groups depending on whether access was provided. So in places where schools were open the whole year, we did see, racial differences in the kind of in person who wanted to access in person, but they were nowhere near of the size of the differences we saw in places that were closed and then opened. And I think also over time, as places were opened, there was a more of an equity in opt-in, because some of what happened is sort of, these are communities that were much more heavily affected by COVID. And then people said a lot of really scary stuff about how if your kid comes to school, they'll die. I mean, so some of the like rhetoric was like, if you send your kid to school, there's a good chance they'll die. That's not true. Like, that's just not true. It may be the chances may be different across different groups and so on, but it's not the case that when you send your kid to school, they're likely to die of COVID. It's just not true. It's not for
Oh yeah, I was thinking they'll bring it home to their grandmother who lives at home or whatever. That's the usual.
Right, but that's not what people are saying anymore. So then once grandma got vaccinated, then it was like, I don't want to send my kid. Now sort of, it was actually a New York Times op-ed, sort of a little bit frustrating the other day, where somebody was like, the reason I want to have access to virtual schooling next year, because if I don't, my kid, the only thing that's protecting my kid from dying of COVID is not going to school. And that's not true. So I guess one thing to say is I think that there's a line between respecting people's wishes, which I think we want to do, and being cautious about the fact that there are differences in interest in this and differences in fear and differences in across these different groups. There's a line between that and kind of making sure that people have the information that they need to make the decision correctly, kind of across, make the decision in an informed way, I guess. And I kind of hope if we did a better job communicating some of the facts, that we would see more often.
Yeah, sorry. Yeah. To kind of respond to that, like Ben, it's almost interesting because you almost want to take a paternalistic view and say we do take some responsibility as the government, as these institutions, for these different minority groups not wanting to go to school, because we know that that early education is so important for later on life inequality and whatnot. So we actually do still want to take that responsibility for making people trust the school system at similar rates. I assume that was kind of what you touched on in the end, Emily.
Yeah, I mean, I think this is a really complicated set of discussions here, but yeah, I mean, I think that some school districts have now sort of taken the view that next year there's no virtual options. This is like a topic of debate at the moment. Are we going to offer a virtual option or not? And on the one hand, if people want a virtual option, maybe we should offer them a virtual option. On the other hand, there's a question of, we didn't typically have a virtual option. What would be the reason to have a virtual option now? And, how do we, and people come down really differently on this. So I'll tell you, and particularly interfaces with the fact that some kids are not doing well with the virtual option. So I was, at some point during this, I was on something with the superintendent of Broward County, which is where Miami-Dade is. And they were in person, but of course, some kids had opted out of in person. And he was sort of the position that I am going to make them come back to school if they are failing, I'm going to make the kids come back to school. And if they won't, I'm going to make their parents sign a piece of paper that says, I understand by not bringing my kid back to school, they're failing and I'm failing them. He had some very, this guy's intense. And so, but it was sort of this feeling of somehow it was his responsibility, particularly to particularly his community of Black students, to kind of push them to say, hey, this is where you should be. And I think that tension is something that we will be struggling with next year.
Hey, Emily, just wanted to say it's great to hear you. In person, I've read Expecting Better because I study medical decision making.
All right.
And I've read the piece about you last week where some people say they view you as the CDC. So they trust you more than the CDC. I think this speaks to a lot of issues that came up today, all of which were mentioned: the issue of trust, the issue of communication, the issue of politicization, because clearly you're a scientist, you don't belong to one party or another, although it's pretty, I guess, easy to figure where you would go, I think, but it doesn't matter because you're not going with red or blue, you're going with science. I think that's alarming in a way for the American communication system and health system, that people are just not sure, they're scared, they're reading you instead of the CDC. Obviously, it's great that they're reading you and not some whack job, out there, but still, what does it say about the way information is conveyed? What does it say about people who are saying, I don't want my kids' reproductive system hurt by the vaccine? Which is, where is this coming from? How do we find a way out?
Yeah, I mean, I have all of the yes, all of those things. I think that it is we really fell down. I think in some sense the idea that anyone would be like, oh, you're my CD, it's like, that's crazy. Like I think just be clear, I think very highly of myself, but not that highly. Like the CDC has a lot of there was a job for someone to do here in terms of communication, that would take into account these things about equity, that think about sort of how to communicate stuff in a kind of broad way. And I think the CDC has done a very, frankly, like a pretty poor job at sort of doing that. It's not just the CDC. I think in general, we've done a fairly poor job. And I think part of the issue is that they are not used to communicating under circumstances of such intense uncertainty. And so there hasn't been a lot of effort to develop ways to talk about, like, here's what we know, here's what we don't know, here's what we're hoping to learn. So, they're very good at saying, we're sure, blah. But and that was kind of the instinct here. Like, it has to be 6 feet. This is like the rule, it has to be 6 feet. Then when 3 weeks later, they're like, oh, it's 3 feet. There's a kind of feeling of like, what? Like, you say you were so sure before, as opposed to saying, this is what we think, here's the data we're waiting for to try to make a different decision. I think there's a lot of reluctance in this sort of communication space to say that, and it leaves space for people to create their own narratives and around things like anti-vaxxing, or like whatever the particular concerns are about vaccinations. It leaves people feeling that their concerns are not being listened to, and that they are just being sort of like railroaded in some way. And I think there are pieces of the anti-vaccination concerns in particular that we should just sort of dismiss. Bill Gates is not putting a microchip in you with the vaccine, and there's not really that much to say about that other than like, that's not what's happening. But then there were these other concerns, like my period got really heavy after the vaccine, which it sounds like is an experience a lot of people had. I'm not saying that happened to me. It's an experience a lot of people had. I don't think we really know whether that is a sort of a potential side effect or not. And rather than just saying like, don't be a crazy person, I think we need a language to tell people, these vaccines are new. There are some rare, potentially rare side effects that we wouldn't have found out about in the trials. We think that here's why we think they're safe for all of these reasons. Here's what we're doing to learn about these things. And there's just been such a reluctance to say that, and so much of a push to just treat every concern like it's a Bill Gates microchip. And that I think it just leaves people feeling unlistened to, and that's been problematic.
Yeah, well, I couldn't agree with you more. I think the issue of uncertainty is very difficult to convey. It's difficult to grasp. And in a way, it almost goes against the CDC's mission of saying, here we are, this is what we know. But the truth is, it's a moving target. So even saying this is a moving target is actually helpful and more honest than saying, these are the facts. And oops, they just changed on us.
Right.
Yeah. Thank you.
But can I just, on this issue of like reproductive harm, which I'm sorry, Sergio, you were ahead of me. I'm sorry.
Yeah, no, I just wanted to go back to the last very colorful graph that you showed us. Suppose you have to do the same exercise, not with race, but with socioeconomic groups. Would it look different? So
no,
what I want to know, are you picking up is the race really picking up the socioeconomic inequality, and you phrase it in terms of race, or is race really meaningful here?
So it would be hard. It would be hard to do by socioeconomic. It's a little hard to do by socioeconomic group because that data is not as accessible in like the NCES. This can be very highly correlated with socioeconomic group. The only sort of hesitation I would have about saying it would look exactly like that is that one of the lines on which this sort of split was kind of like big urban districts being much less likely to open in person, and kind of poor rural districts being more likely to. So, there are a lot of pretty poor places in the US and like, West Virginia and Tennessee and Kentucky and so on that basically opened pretty much like just regular in person. And then there are there are places like New York or Chicago that didn't open. Now, so I think this is more bifurcated on race than it would be on income, but it would look very similar, and it would look very similar if you do Title I schools. These things are just super highly correlated. So they're just super highly correlated.
On this, on a lot of issues like the reproductive harm and things like this, I guess the public health, you may have touched on this earlier, but they have this hypothesis testing framework, and I think in a lot of things like masking and how the virus spreads, we just have good reasons to, if you're sort of Bayesian, a lot of economists who are commenting on this thought, it's kind of even though we don't have any gold standard evidence, it's kind of obvious what is likely to be the case. I wonder if for something like, something that we really can't know much about other than by analogy with other situations, is it your view that the public health infrastructure should get good at basically sharing their Bayesian beliefs with the public? Because I think it's you could see that to the point of this being politicized, or at the very least, whatever all the flaws of the hypothesis test, at least it's not bringing someone's prior who might be viewed as malevolent or whatever, right? So it has some hope of maintaining credibility in a polarized world. And if it's you and me and a lot of other reasonable people get together and share our best guess about birth defects stemming from vaccines, I just wonder what your view is on that.
Yeah, I think one way to say it is they should get better at sort of sharing their posterior or whatever it is. I think the other way to say it is I think they're even reluctant to help people understand why someone's suggesting something. So sort of putting aside the menstruation things, this issue of fertility, which was the sort of source, as far as I can tell, from this idea that the vaccine causes miscarriage, is some anti-vaxxer group in the UK or in Europe that suggested that the spike protein that looks like the placental, looks like some important spike protein in the placenta. It doesn't really. All proteins look similar; they're all made of the same stuff, but it doesn't actually look that similar, and that therefore was going to cause some kind of rejection in some way. So I think even I have found even explaining that to people is very helpful. This is where that came from. Because if you don't know, well, why would someone think this? If your idea is just to be well, it's not true. Okay, but I read something that said it was true, and you haven't told me why I saw that, and it sounds to me like you're trying to hide something. And so I think that we could get better at even doing a little bit more to explain why, even though we don't have perfect evidence about this, why we don't think that is something we're concerned about. And I think that they're just very reluctant to do that because it requires acknowledging our evidence isn't perfect. But of course, if you don't explain it, then people just sort of fill it with their headspace, which is bad.
Emily, I wanted to ask you about something that I thought you would do, and as far as I saw you didn't do. I was wondering could you take two states which were rather similar in terms of how the rate of infection, and then in one of them the schools remained closed, and in the other they were opened, and compare between them? Or is that for some reason something that you thought that there was a problem to do?
So to look at the impact on community rates of school openings, is that what you mean?
Yeah.
No, so actually there's a bunch of papers that do that, and we're working on one that does it. That does it now. That actually turns out econometrically to be, and I would say the results are sort of mixed. Some people say it's up a little bit. Some people think it's zero. It depends a little bit where you're doing. And I think the things that are complicated are number one, exactly how you would interpret those results a little tricky, because is it things that are at the school, or is it the fact that we opened the schools at the same time we did everything else, or opening schools were taken as a signal that you could go to the Olive Garden or whatever. That's a restaurant, the Olive Garden. I think the other thing is econometrically, this is a super complicated problem, because basically schools open in September. You then have some kind of complicated expected lag structure between opening and cases and hospitalizations and death, which sort of has to do with the timing of those things. Plus there's this sort of surge in that period in general. So, I think we have tried to work on this. A bunch of people have tried to work on this. I would say the effects are, kind of probably small in either direction, and possibly variable with some other things about the place, roughly.
If I may ask
Yeah.
one more question,
Of course.
do you have is there any way to quantify the increasing probability of infection, of being infected by going to school relative to other activities? So not just look at the end, so one is looking at the end result, but somehow one can compute probabilities given the number of meetings, given the number, I don't know. I mean, I don't know how serious those exercises are, but can I compare one day in school to say 1 hour at a restaurant? What increases my chance of being infected more? Are there any meaningful computations like that?
No, I don't think we have. I don't think anybody has.
Just complete guesses and nothing.
It would just be complete guesses. Yeah, it would just be complete guesses. I mean, the number of student infections in schools that are sort of known to be traced to schools is extremely small. There was this study out of North Carolina with they followed 90,000 people over 9 weeks. And they found, 72 infections or something that were spread in school over that period versus, 800 kind of primary infections that were sort of elsewhere in the population. So, and almost all of those in school were either staff to staff. There were no infection student to staff over that period. And so, it's just the numbers are just really small, and sort of we just don't have, and we don't even know how risky is it to go to indoor dining. I don't know. Nobody knows. Could be anything.
Okay.
Emily, you showed us at the beginning of your talk the fall off in student learning after schools shut down in March 2020. What about what has happened
next year
since September? I mean, for example, can you compare student performance in all in-person schools with hybrid or online learning?
You'll have to have me back to do it. Yeah, I mean, I think it's so we don't have sort of with official data, it's very difficult to do that because they basically didn't do any of the testing that they would normally do this year. But that same data set, that Zern data that we're going to sort of you can merge in with sort of information on opening modes, and kind of by and large, I think it's starting to look like there's the effects are not as large as they were in the spring, but they're still there. But I think more needs to be done with that. And my guess is in the next sort of year, one of the big projects we have over here is we're trying to put together a data hub where we actually have all of the schools opening modes sort of over the last year, which will then be effective at sort of merging it in with some of this learning stuff and thinking about disruptions and just overall opening modes and so on.
So I've seen a lot of literature about how they're not only concerned about the current effects of, these school closings, but that there might be some embedded, inequalities later in life, even after everything returns to normal. Do you have any plans on trying to study that phenomenon?
Yeah, so I think our big, the sort of what we're trying to do right now is we're trying to basically pull in from a sort of national data set. I'm trying to put together and make public a national data set on school reopening modes over the last year, ideally for every district and school in the country. I don't think we'll get there, but I'm hoping we'll get close. And then one could, researchers will make this public and people can sort of merge it in with whatever they want in the long term. And so then when we want to ask questions like, what are the long-term mental health impacts and long-term schooling impacts for this cohort of students who are affected in this way, that we'll have the kind of data in place to do that. That's the goal.
Does your data track for that long? I guess it would have to, because it's just district by district, right?
District by district, yeah, exactly. You just eventually we'll have NAEP data and all this other stuff, mental health, where we'll if you have it sort of identified at the school or district level, district at least you can track to things. Zip code.
Okay.
Any other question, comment? Thank you very much, Emily.
Thank you very much. It was great to see everybody.
Thank you.
Thank you, Emily.
We will resume at 5:45 Israel time, 10:45 Eastern time, and Parag will talk to us about priority systems. So please come back in about, how much is it? About 20 minutes.